Anyway, I'm Kurt Newman. I'm the president and CEO here, and it's really my honor. I was asked to introduce the topic this morning, and because Dr. Batshaw is observing Yom Kippur this morning, and many of our other faculty, but we felt that the topic was important, and I was asked, and I think as CEO, I wanted to emphasize the value and priority that I place, that our board places, that our leadership places on our academic mission, on our research, on our education, our innovation, and creativity. And so, you know, it's a special privilege for me to be able to talk about that. And what we are specifically focusing on this morning is the Clinical and Translational Science Institute at Children's National. This is a huge deal, whether you know it or not. If there's one takeaway for those of you that rotate through here or maybe not conversant with research, Children's National is and this institute are the only pediatric-focused institute like this that the NIH provides in the country. So all of the other institutes, all of the other 63, I think it is, institutes, there's 64 total, are led by adult institutions. Might be Harvard, Penn, University of California, San Francisco, UCLA, and so forth. But Children's National is the only pediatric, and this is the only pediatric focused DTSA that is focused on child, and it's focused on child health research. Now, we are privileged to have a strong partner, a strong academic partner, and that is our colleagues and partners at George Washington University, and we have some colleagues here, and there's at least one here, and I think Sheila will be making that introduction shortly. And because you can't go this alone, and we have a wonderful, this is a grant that's written together, and all of the resources are merged together. And it's because we took the tack of having a child and pediatric research focus that George Washington was, I think, gracious in having us be the lead, and then they being our partners. You're going to learn a lot about the CTSA this morning, and the purpose of this award is to really help people learn to do research and help people to learn how to study, how to develop careers, how to take advantage of resources. And we are so poised for that type of opportunity being here in Washington, D.C. We've got the NIH here, the FDA, a lot of the military research facilities. There's a lot of private industry focused on research, and more of it is focused on pediatric research, and that's the special role that we can play. The award, we just got re-upped for the award. We had to go back through a competitive process. Many organizations are not able to get it either the first time or the second time. In fact, we had to go back, rewrite ours and go back in, but we were thrilled to get the award, and it's for over $20 million, $24 million. It's a 5-year award, so it's a big award, and this is the way that the NIH is delivering resources for clinical research. So this is it, and so to be one of those special centers that has one of these awards, and I can tell you who we beat out, and their names you've heard of. I mean, these are big names that weren't successful. And it wasn't unusual not to get it or to have to go back in. I think I remember that both Johns Hopkins, Duke, a couple others had to reapply and get there. So that's part of the process to get these awards. So the ultimate goal of ours is to improve the quality of life for children and their family. Think about that. I mean, that's what we do as a hospital and health system, but this is how we want to use our research. And specifically, we want to enhance the training of the workforce, and that's not just physicians and not just scientists, but it's looking at our other colleagues, nurses, pharmacists, the whole team of providers. And it's also focused on taking discoveries and getting them right into clinical practice. It's not enough just to have it work in the laboratory, but the goal of a CTSI is to take that research and make sure that patients are benefiting from it. And we want to use the resources to tackle the big issues. So that's where the priority is. So it's chronic diseases and things that, for example, that affect a large portion of the population. But in ours, it's focused on child health. And then the other thing, and I think this is where it's very creative and innovative, is to create that ecosystem, if you will, of all of the different pieces that are required to be successful. So it's not just enough to have a smart investigator, but they need the ecosystem, the things around them, whether it's the information systems, the statistics, whatever are the tools that researchers need to be successful. So we are, again, I would say we're extremely proud to have this collaboration with George Washington to be successful in our grant. Lisa Guay-Woodford is the director. She couldn't be here today, and Dr. Miller, Dean Miller, is the co-director from George Washington. But in some ways, it has created an opportunity for the talk to be given by one of our superstars, and that's Sheila Magge. And it's an inside joke, where's her brother, about who's a neurosurgeon on our staff. We just have two superstars from the same family. That's very, very unusual, I think. But Sheila, I'm not sure. Well, I can't pick. They're both great. I'm sure their parents had trouble too. But Sheila's got a pretty awesome resume. Just the highlights of which are that she did go to Harvard undergraduate, where she went to where she studied biochemistry. Then she made an interesting move down to Yale to go to medical school. You know, there's a kind of a joke about, well, it's not a joke. It's something I always thought was funny. Maybe I'll give it a try. So President Kennedy went to Harvard undergrad, and then he was elected president, as you know, and he was then offered a honorary degree at Yale. And so he decided to accept the degree. You know, there's a little bit of rivalry between Harvard and Yale. So he decided to accept the degree. And in his acceptance speech, he said now that he had the best of both worlds. He had a Harvard education and a Yale degree. And I always thought that was kind of a little big there. But Sheila went to Yale, did really, really well, then went back to Boston to get her residency training at Boston Children's. She also got a master's at Penn along the way. And then she went down to the Children's Hospital of Philadelphia, CHOP, to do her fellowship. And then we were successful in recruiting her to Children's National a year and a half ago, or 2.5 years ago. to join the endocrine division, but also be part of the CTSI, and she serves as an associate professor in pediatrics at George Washington School of Medicine. So with great pride, I introduce Sheila Magge to you.
Thank you, Dr. Newman, for that very kind introduction. My brother and I appreciate it. So it's my great pleasure today to talk to you about the Clinical and Translational Science Institute at Children's National, version 2.0. Our director is Dr. Lisa Gay Woodford, as Dr. Newman mentioned. Our co-director at GW is Dr. Robert Miller. And I'm presenting today as Lisa had to go out of town. So soon after he became the chief of the NIH, Elias Zerhouni convened a series of meetings in order to set the roadmap for biomedical research in the 21st century. And as such, the purpose was to identify major opportunities for research and gaps in biomedical research that no institute on its own could tackle, but that the agency as a whole could address and really make an impact in research. So as such, in order to make that biggest impact, they saw a gap in the translation of biomedical discoveries into healthcare, and thus developed the Center for the Clinical and Translational Science Award Program. So based on Elias Zerhouni's vision, as well as the roadmap for medical research, and with community input, the CTSA program was established in 2006. So as building on the mission of the CTSA program, our vision at CTSICN is to promote innovations that feed the translation of research into improved child, family, and community health. Our mission is to foster broad collaborative investigation that accelerates discovery and drives dialogue across the bench, the bedside, and the whole community. So as Dr. Newman mentioned, since 2010, the CTSICN has been a partnership of Children's National Health System and our academic partner, the George Washington University. Now, the National Center for Advancing Translational Science, or NCATS, which is the NIH funding institution for the CTSI, came up with 5 consortium goals that are listed here. So we have workforce development, collaboration and engagement, integration, methods and processes, and informatics. So with the goal of identifying new methods to more efficiently translate biomedical discoveries into improved interventions for health, they developed the CTSA program as an integrated research and training program that creates an environment for clinical and translational science that aims to dramatically improve the efficiency of translational research across the spectrum. So what I want to focus here today is what CTSI can do, CTSICN version 2 can do for you. So can we, if you're the investigator, can we build your database, recruit your patients, design your study, prepare your IRB proposal, you wish, I'm sure, run your study, provide community outreach? Unfortunately not. However, what we can do is help you build your database, recruit your patients, design your study, prepare your IRB proposal, help you run your study, and community outreach. So similar to a tackle box, we want to provide you with the tools and resources that you need to catch the big fish. So the CTSICN has these resources for you to help you be successful at your clinical and translational research. So without going into a lot of detail about the infrastructure of the CTSICN, these 8 are components, are cores of our CTSICN, and included in those 8 cores are 14 modules encompassing different expertise. Now, for you as the investigator, when you have an idea, what should you do? So you start out with a Spark request. So Spark is the portal right there mentioned, spark.ctsicn.org. And there we have navigators to help guide you. So the Spark is an online portal where investigators and their study teams can submit a request, obtain information about research services at CTSICN. It also allows for the development of budgets and communicating directly with service providers. So here I have listed some of our navigators in the administrative realm: Nicole Banks, the participant in clinical interactions, Camille Colvin, research, Joanne Wilson, regulatory, Elena Gibson, and GW, who we're to be announced. So first, we have 4 themes that have been established in our CTSICN. 1 is the health of children and families. 2 is rare genetic diseases. 3 is novel devices for pediatric care. And 4, child precursors of adult disease. So themes 2 and 3 were built on children's national strengths, for which we're internationally known. Themes 1 and 4 are a natural outcome of our partnership with GW and the transition to adult care. So how can we help? So one of the ways we can help through our administrative core, we help investigators with the cost of their services and resources. So we have a voucher award program. With that, an investigator can get up to $5,000 per investigator per year to help with high-impact research in areas such as immigrant and refugee health, child-adolescent obesity, global child health, mobile health applications, research that reduces cost or time to bring orphan disease products to the market. And you can find out more about these voucher programs here at the CRI website. Now, with your idea, you're going to need help with informatics. So our informatics team can help you build your databases and can help you recruit your participants. So our informatics core has several different tools. Now, to help you identify your cohort of potential patients, we have I2B2, Trinetics, and Endeca, and these are 3 tools through the electronic health record. Now, I2B2 is it's a data query tool that, based on user-identified criteria, you can identify potential research participants. Trinetics sits on the I2B2 platform and allows you to do feasibility searches of the EMR to find out whether you have the patient population here to do the study that you want to do. Now, Power Trials is a Cerner program. It's part of Cerner, and it's an EHR tool that helps you identify potential research participants at the point of contact, so at your visit, your clinical visit. Now, another tool that we have at our institution, which I think is a great one, is Protocol Builder. And this provides assistance with developing an investigator-initiated protocol. So Protocol Builder is a secure web-based application that helps investigators develop high-quality, investigator-initiated protocols faster and easier. Now, it has 16 protocol types. So as you know, when you're doing an observational study, that's very different than an intervention study. There are different components to that protocol that you need. And the great thing about using Protocol Builder is that it prompts you for the necessary fields that you need to fill in. For example, you're writing a clinical protocol. When you're talking about your study drug, it'll prompt you for safety information about that. Or it'll prompt you for DSMB. Do you need a DSMB? If you're doing an IND protocol, they involve very specific regulatory components. And this provides a standardized protocol with all the necessary regulatory components. So it's really a nice tool that the institution has purchased for use. Now, in addition, we have database development. So we have REDCap and we have OpenClinica. OpenClinica is a HIPAA-compliant database for IND protocols. We also have REDCap. So REDCap it's a web-based tool that has different functionalities. It can produce surveys. So you can do surveys with different forms. So you can use true, false. You can use text boxes, multiple choice. You can also create your database, and it's a very intuitive interface, so it's easy to use. You can import data from an exterior source into your database, and you can export the data from your database into a statistical program like Stata or SPSS. And that makes it very helpful and easy to use. So we have many training sessions here at Children's. I've been impressed with all the REDCap training sessions that are open to everybody, and you can request an account, username, and password. So now let's say you have the idea and you want to do community engagement, you want to do research in the community. We can help you. So first of all, we have programs for continuing education for community clinicians to learn about research ethics, recruitment, and retention. We have community engagement and cultural competency training. In addition, there are links between community groups and KL2 Career Development Awardees and Pilot Grant Awardees to connect the researchers with the community. Now, we also have links for researchers that are seeking ties with community-based organizations such as patient advocates. So we can also help you develop your research project. The DC Health Matters portal is a portal that the design was led by Chaya Merrill from GW, and it can assist with measuring community health. It shares best practices as well. And we also have Science Cafes 360. So these are quarterly gatherings of scientists and community members at platforms like, you know, in a coffee shop in the community, and it allows for bi-directional dialogue. So it's a really neat, I think, atmosphere for scientists to talk to community members and just back and forth. So now let's say you have an idea, but you need pilot funding. So we have a pilot and translational clinical studies program. Now there's 3 different pilot opportunities here. We have the Discovery Research Pilot Program, which focuses on hypothesis-driven research. We also have the Translation Acceleration Pilot Program that focuses on barriers that might involve methodological issues, institutional structures, early clinical feasibility. And so, for example, if you have some big statistical conundrum that you are working on, you can apply for pilot funds to help you engage our Biostatistics Core to help you overcome that obstacle. We also have a community-based research pilot program which is being developed right now. Now the process, we just finished our fall cycle and we will have our spring cycle in 2017, and there are 2 steps. First is phase 1, which is a letter of intent. And then we have phase 2. So if your letter of intent is accepted, then you will be invited to submit a full proposal. Now, to be eligible, you must hold a doctorate degree or equivalent and be a junior faculty member. It's also open to associate professor or higher if you are changing your emphasis of research. It provides $50,000 per year for one investigator, and it's really a great opportunity for investigators to use. The proposals are evaluated by scientific merit using the NIH criteria. So for our first cycle, which just ended, phase 1, we received 24 letters of intent. 22 were accepted for full applications. Then we received 21 full applications, of which 15 were from Children's National, 6 were from GW. We completed our reviews, and the pilot team is meeting now to discuss and rank the high-scoring applications for funding decision. And depending on the applications we get, we have the capacity to fund up to 10 applications per cycle. So that is quite an investment in you, the investigator. We also have the KL2 program, which is an institutional career development program for junior faculty. Again, you must be a U.S. citizen or permanent resident and hold a doctorate degree, junior faculty member, and you could not have held an R01 or another career development award. Now, this is a great award, and speaking as somebody who had an institutional K and then a K23, and now I have an R01, but this was invaluable because it protected 75% of my time for training and research activities, including coursework, workshops, and individual programs of study. It's for a focus on human-centered or human-oriented translational research. The investigator can develop a mentorship team. So if one doesn't exist, you can pick and choose and create your mentorship team, which is something that I did. And it's a great opportunity. And you participate in the activities of the CTSICN as well. So our Grants Enhancement Program, led by Dr. Peter Scheidt, is a really unique and special program that I would encourage everybody to take advantage of. So let's say you're a new investigator. You want to first go to your division chief, and your division chief, the chief medical officer, academic officer, and talk about your research interests. Your division chief or research director will likely point you in the direction of research mentors, and then can also have you interface with our Grants Enhancement Program. So there's 3 different aspects or ways you could touch your Grants Enhancement Program. One is, let's say you have a concept, but you haven't fleshed it all up. You can give a 10-minute presentation to some of the CTSICN leadership, module leadership, and they can help you flesh that concept out and come up with your ideas. Now, let's say you want to refine your aims, your specific aims further. We can do that through our Grants Enhancement Program work groups. And Dr. Scheidt will also work with you and review one-page specific aims, that front sheet, or guidance with the entire proposal. Now, recently, Dr. Badshaw, our Chief Academic Officer, has mandated that junior faculty who are trying to apply for an NIH grant go through the Grants Enhancement Program first. And I think that's really important because this can make the difference between a good score or being triaged, which is okay. It happens. So now let's say you have an idea and now you need statistics help. So we can help you design your study and help you analyze your data. So through the biostatistics, epidemiology, and research core, design core, and we call it BIRD, we provide direct investigator support. Now, BIRD can provide biostatistical and epidemiological expertise for the design of your study and development of child health clinical translational studies and support data analysis. So there's no charge for pilot or K grant applicants. So if you're applying for a K award, there's no charge to meet with part of our team, which, excuse me, read by Barbara Carter, and and K awardees get up to 20 hours of free support. Now, all investigators are allowed up to 4 hours of free support with our BIRD team as well, which is great. So we also offer formal coursework opportunities in biostatistics. So there's a certificate in clinical and translational biostatistics, which is 15 credit hours of coursework, and can come from our Master's in Clinical and Translational Research program. There are foundations, biostatistics, clinical investigation, and epidemiology. There are other learning opportunities through monthly lectures, bringing your own data to workshops where you can interactively work on your data in hands-on sessions, and then mini seminars, which are led by experienced methodological educators who can help explain, in somewhat lay terms, complicated concepts like Bayesian study design. So our hub research capacity. Now let's say you are ready to conduct your research. This is where the participant and clinical interactions module comes into play. And I'm the lead of this module, so I'm a little partial. We can help you run your study. And so in the past, you might have been familiar with a clinical research center, so the GCRC or the CTSI version 1. So there we had dedicated clinical research staff who could provide direct support for you in your patient-related research activities. They could help you do the oral glucose tolerance test, the PK studies. Now, a big change in version 2.0 is that the NIH has changed what it allows. So it no longer allows, it will no longer pay for us to provide direct procedural help. So their new directive is that their funding can be used to support clinical research staff only for oversight and quality assurance, but not to support the actual research activities that are part of a study or a trial being conducted at the site. So, for example, the CTSA funding can be used to support a limited number of experienced clinical research professionals like research nurses, coordinators, and they can facilitate access to resources, help you with providing oversight, helping with quality control and assurance. Now, they also state if a pool of coordinators of research or research nurses are available to conduct participant interactions, their activities must be charged to the study budget itself. So in response to this new NIH directive, which could potentially be a significant change, right? Our CTSICN, we've established a pool of research nurses and clinical coordinators who can provide guidance, oversight, and quality assurance for your study implementation and are available to assist investigators in conducting the evaluations if you charge your if the activities are charged to the study budget itself. So as a per patient fee. Now, the CTSICN can help defray the costs using our voucher system, and it's important to remember that you don't have to panic if you have an ongoing research study in our research center. You will be grandfathered in. So that's going to continue as it has been. But what's critical is when you write your grant applications now, you need to be in touch with us. Our administrative lead is Camilla Colvin, and she'll help guide you to account for us in your budget ahead of time. So we provide a lot of other services as well, and I would encourage everybody to take advantage of them. We have neurobehavioral and psychosocial evaluation core. So we have tremendous expertise in psychology, neuropsychology, and we can do assessments of cognition, behavior, social, environmental, and family dynamic assessments, as well as consultation for behavioral phenotyping or selection of the optimal tools to use. We have a bionutrition core, so we can do extensive services like dietary assessment, special meal design, anthropometric measures, so skin fold thickness, waist circumference, body composition measures like percent body fat, et cetera, energy expenditure, and you can use up to 4 hours free to develop your hypotheses and preliminary data. You can also, and then we also encourage you to build those services into your budget for your upcoming research. We have a biorepository as well where we do biospecimen collection and processing. We can do DNA and protein extraction and storage for IRB-approved protocols. And we do data and sample management using Freezer Pro LMS, which is our lab management system. Now, here we get into the scientific review committee. So the CTSA consortium was charged with proposing a framework for scientific review processes at CTSA institutions. And they came up with a scientific review committee pilot project. So this is for research involving human participants in order to be compliant with ethical standards. Because a human study that is improperly designed is inherently unethical. Because if you don't have the adequate sample size or you don't have the right study design, it's unethical to start recruiting patients into a study that cannot accomplish your goal, right? So our goal is to enhance protocol, scientific quality, and the potential for success, ensure ethical standards, and also maintain efficiency. So the CTSICN was honored to be chosen as one of 12 sites for this pilot program, which is coming out of Tufts. We were selected last year, and it's to be implemented this year and this month. And the idea is that we will use a tool for scientific review, and it's really nothing that's out of the box. It's very obvious quality criteria, such as, are you identifying an important question? Have you outlined specific aims clearly, hypotheses clearly? Do you have the proper design to answer the question that you want to answer? Do you have statistical analyses planned out? Have you done a power analysis just to make sure you have an adequate sample size? So it's nothing that is incredibly unusual or anything counterintuitive, but by doing so, we hope to improve efficiency by not bogging the IRB down with a lot of studies that might need help with their scientific integrity. As part of the pilot study, they are also collecting data on efficiency, how long it takes to get through the review process. And I will say for institutions that already have SRCs in place, they compare before and after. Now, many institutions, such as my previous ones, have had these in place for years, and I was a member of our SRC previously at CHOP, and it really helped improve protocols and help the investigators to improve their protocols before it went on to the IRB stage. 10 out of the 12 in the pilot program already have SRCs, so they will be comparing to their processes before. We've had the advantage of not needing to compare to anything, but we're going to embark on this shortly. So now, it's going to be launched, as I said, this fall. Its aim is to promote rigorous scientific assessment, improve the quality and the ethical compliance of human research, and we're going to be reviewing pilot projects, projects by K awardees, trainees, maybe institutionally funded, investigator-initiated studies, small foundation grants. However, any R01 studies, K23 studies, where the protocols have already been reviewed for scientific integrity will be exempt. And that will include many of your industry studies where the protocol's already gone through the FDA. You will be exempt from that, and it will go straight to the IRB. So the question that would be on every investigator's mind is this going to delay the time for my research to be approved by the IRB? And the goal is no. So we want to facilitate submission of high-quality research protocols to the IRB, thereby reducing the delay in approval due to concerns about scientific validity of the protocol. The IRB team is actually very happy and excited that we are doing this. They feel that oftentimes they are having to stop the regulatory evaluation and really kind of get bogged down in the scientific question. So they're actually excited that we are doing this so that they can then focus on regulatory issues. So the SRC review, what we are planning to do is have a scientific review committee, and for each protocol that comes through, we're going to assign a reviewer with clinical research expertise and a reviewer with content expertise. They'll review the protocols, present them to our committee, and then we will make there will be one of 4 outcomes. So it could be approved, it could be perfect, and then it's released to the IRB for review. Minor revisions. So if there's small revisions, we would then release the reviewer's comments to the PI, who could do a rapid resubmission for review within 2 weeks by the same 2 people who originally reviewed it. A major revision, the committee will meet with the PI, give them the comments and the review criteria from the review team, and then they can resubmit it and then reject. And I do think this is going to be a minority of protocols with multiple scientific, ethical, or feasibility concerns. So I think the vast majority are going to be here, the minor or the major revision, with a minority on either end. Now, just to shift bases off the SRC a little bit, another innovation that we have in our CTSICN version 2 is the Clinical Study Support Program. And this is led by Ray Panis, who's in our audience. And this was created to address an issue, which was that existing clinical trial structures and processes are often siloed, creating barriers that delay both the activation and the completion of clinical studies. So we saw an opportunity to improve the integration and the interaction and to increase efficiency, research performance, and clinical trial revenue as well. So as a solution, we developed this comprehensive centralized clinical studies support program through the application of quality management principles. The benefits are that you're going to advance the quality and value of clinical research administrative services, enhance the infrastructure support, foster communication, improve the efficiency of the operational processes, and avoid duplication of effort and busy work, basically, while establishing clear accountability and responsibility. So here you see you have all of the different operational units of clinical research at Children's National, the CTSICN, CRI, Sheikh Zayed, financial, all of them. And the way this is set up is that they will function under the umbrella with a dotted line to the Clinical Studies Program. And in that way, they're still going to keep the operational leads will report to their program lead as they have been, but there'll be this dotted line so that the clinical support program will be aware of the ongoing processes and any changes in the workflow of those individual components. So, for example, if the financial module here, if this operational kind of component has a change in the process that they want you to use for submitting your budget, sometimes it's hard for the investigator to keep track of all the changes that are going on in a different operational module. And in this way, the CSSP will keep track of those changes. They'll know how each of these operational units work and any changes, and they'll be able to transmit that to the investigator. So the plan is that if you are, starting out and you want to do research, this CSSP person could be one of your, after you've talked to your division chief and the leadership, you can then come to the CSSP and meet with Ray and his team, and then he will help guide you as to the best places to start. So we encourage you all to become a member, and this is our CTSICN website here, ctsicn.org. It's going to look a little different because it's being revised and renovated to address our new version 2. But here you see the website. You can become a member right here, and you'll receive then all the announcements for pilot applications, voucher awards, and all the different opportunities that we have to try to help you be successful at your research. So with CTSICN version 2, we're accelerating discoveries towards better health by increasing innovation, efficiency, and impact of clinical and translational research as it applies to children. Thank you. So I'm going to invite our Director of Operations, Amanda Casper, to come up if you all have any questions. Dr. Teach. There's only one Dr. Teach. Oh, the microphone. Oh, sorry.
Sheila, that was a really incredibly concise summary of everything that the new V2.0 has to offer. And for those of us who've watched this evolve over the last 10 years or so, and been part of all the grant submissions, it's just so wonderful to see this has matured into this highly integrated, very tight operation. So congratulations to everybody who's been involved in that. My question is a little bit different, though. What does success look like?
That's a great question.
How are we going to judge CTSI V2.0 in 2 years, 4 years, 6 years, 8 years? How will we know that it's succeeded?
So that's a great question, and in our business plan, we do have benchmarks for the amount of both the use of our clinical, specifically from the point of view of our CRC, we have benchmarks for usage of our facilities, the number of studies that come through our facility, the revenue that we bring in from clinical trials, from pharma, from different agencies. And I also think that when we first started, our administrative lead, Camilla Colvin, sent out a user survey for everybody to share with us their comments. What has their experience been with version 1? What were problems, impediments, any issues that they have? And we've really tried to address those issues, make us as approachable as possible. So I would encourage anybody, sometimes I ask people if they're using the CRC or PCI, and they say, oh, no, I had this experience 10 years ago where blah, blah, blah. And that was 10 years ago. Don't base anything on, and it's been a great and successful program, but I just encourage you, because we keep offering new things, and we have new resources for you to use, so I'd encourage you to use us. And I'll let Amanda speak to the grant as a whole.
Yeah, it's can everyone hear me? Okay, it's multifaceted, I think, success, and so that's success as Sheila's defined in the PCI space. Our pilot award program, which you're very familiar with, we're looking at manuscripts, publications that have been accepted for publication. We're also looking for secondary receipt of awards based on preliminary data received by the pilot award funds. And Bob McCarter and the Evaluation and Continuous Improvement team is working with the national consortium as they, too, are trying to refine what does success look like. How do we know that the CTSA program is impactful? So those are just two examples. There are a number of other modules that have their own various metrics that define success.
And as part of our application for each separate module, there was a metrics section at the end to assess it. So that's how important it is to the NIH as well.
Mm-hmm.
So I think it's on. I do clinical trials, and we do a lot of PK studies as phase 2 study design. So we've always used the third floor space for that. And with the new nurses, there was really a seamless handover. We showed them what we needed in the protocol. We had the tubes for them. They put the IV in and put the time course up. But it's not difficult, and we've always had in our study budgets the monies that are allocated to the PK draw, and that just goes directly to the CTSI to rent the nurses, if you will, for the time it takes them to draw the specimens and for their associated personnel to process them, and then we ship them off to wherever they go, frozen on dry ice. So we've had no issues, and I think I would echo what Sheila's saying, which is that when you think it's not a place where they can help you, they're more than willing to help. And they will work with you as a team. It's just working with the budgets office to make sure that you have the appropriate funding in your study budget, especially with industry, to pay for the time it takes to do the work correctly.
Thanks, Adelaide. And that was not a plan.
That's just me.
I just thought I would say one or two more words about the evaluation process. So the CTSI, why don't you introduce yourself? Oh, okay. I'm Bob McCarter. I'm an epidemiologist, biostatistician in the BIRD group. But somehow I got roped into doing evaluation as well. So when the grant went in, we spent an enormous amount of time with each of the different components, making sure that the aims would translate into product, into things, tangible results that could be counted, evaluated, cataloged. And the NCATS has has taken this approach to a next level, and that is they're building in common metrics for a number of the operations that are part of the CTSI, and so that's Amanda mentioned some of these, so I won't go into that any further. But we're doing a lot of evaluation.
Any other questions? Morgan? Okay.
You need a microphone.
So I just want to ask about space. For example, I'd like to get a biolab so we can do interesting behavioral studies, looking at stress and so on. Will there be space for that? And are we still going to be able to use space in the way we have to date, or are we going to need to charge the space use to our grants? Or will that be under indirects? That's a little confusing to me.
So the CRC, or the PCI, all these acronyms that are an acronym salad, but at any rate, is currently working with hospital leadership to review use and space of the existing CRC. And so if you have specific questions about your protocol, I would encourage you to reach out to Alina Gibson, who's sitting here in the front, as well as Camilla Colvin, and they can address your specific question.
Thank you.
Sure. But we are open to anything. We're very open to our investigators to know what they need, and that was part of the process with the survey, because we want to know what you need. and we are reevaluating everything right now in terms of space.
Thank you.
All right, sir.
Well, thank you very much. Can everybody who's involved with the CTSI stand up? I just want to, whoever has studies or, you know, engaged with, so that's looks like a small group.
Whoever has studies, too.
Well, were you embarrassed?
Yeah.
To stand originally? So, and I know we have been using a lot of acronyms, but to me, clinical research, if you're interested in doing clinical research, it's got to be coordinated with the CTSI. And I would say also that it is key to be aligned with your clinical leadership, so your division chief and the chief medical officer and the chief academic officer. Because if space or some bigger issues or compliance with billing are part of your research, it will not go anywhere if you're not aligned. And it could create institutional compliance issues. And we've been working hard on that so that patients cannot be billed for research studies if they're, or they can't, you can't be billing an insurance company if you're doing a research study, and that can lead to huge issues, not only for the investigator, but for the organization. So that's I hate to be Debbie Downer, but, you know, we got to do that. I think implied in the question about space is, you know, the needs of our patients and families and our research and academics, and we are, you know, continuing to work hard to identify how to expand. There's no doubt that we're going to expand, but just how and when, and the resources required, the fundraising that's involved. So there was just a facility master planning process that I know that the CTSI was engaged in, and I was in those offices, and I think they were ready to tie me up and keep me there until I made a promise. But this is, you know, success breeds success, and the great work that's being done, I think. And to add on to what Sheila and Amanda said is, I mean, the ultimate, and this goes back to Dr. Teach, who also did not identify himself, but Dr. Teach is the chair of pediatrics at George Washington and a longtime faculty member and physician here, is the impact on children and on children's health and on our community. And that is really the ultimate bottom line. So these others are kind of surrogates in some way. They're process measures, how the grants, of this, to that. But, you know, ultimately, we want to have a big impact on children's health. So, you know, that's the real key that was implied. I thought this was a fabulous talk. Sheila, thank you, and Amanda and the rest of the team for bringing it to us. It's just a window. It's a, you know, just kind of a taste. You know, go to the website, you know, and do it early, and do it early and often, because this is how you'll develop your academic career. I also wanted to point out, this is not just for doctors. Sometimes it just sort of seems like that, but we have a lot of PhD nurses, and they are encouraged, and that's actually a part of the success factor, I believe, is, you know, the breadth of the teams and who all's involved, and be really creative. And community members of the team are also critical. Who are the other partners that we can bring to this? In case Dr. Merrill was listening carefully, Chaya Merrill, she is Children's National, so I just want to be sure that that she's part of our community, the CHI, and all of that, and is just a terrific leader. Am I correct?
Yes,
yeah. Correct. Okay. I'm sometimes wrong, but never in doubt.
Anyway, thank you all for being here today, and thank you, Sheila.